I'm Dr. James Song from Frontier Dermatology, where I currently serve as our Director of Clinical Research and the Co-Chief Medical Officer based in Mill Creek, Washington. And I'm coming to you live from the 2026 American Academy of Dermatology meeting here in beautiful Denver, Colorado. So I participated in several sessions. So one of them was the inflammatory skin disease in skin of color patients, and I focused primarily on the psoriasis component. What we know about psoriasis, it's the same immunological disease, for the most part, across different skin tones, races, and ethnic groups. But what we do still see are differences in treatment outcomes. And I talked about why that's the case, and there are 4 reasons. First, it's the diagnostic uncertainties. So a lot of people still struggle with diagnosing psoriasis in patients who might have more color in their skin, and that leads to a delay in treatment. Also, inequitable access. Patients are not able to get access to dermatologists in a timely fashion, and even if they do, they aren't necessarily moving on to a systemic therapy as quickly as others. Third, treatment nuances. Not understanding that there are differences in treating patients who have more pigment in their skin or different hair types. And then 4, a lack of data in clinical trials that are representative of patients of color. Okay, most of our clinical trials are actually recruiting mostly Caucasians. Sometimes 95% of these studies are going to be white patients. And so that's a really kind of big treatment gap that we've had for a long time. I presented one study in particular that looked at guselkumab, an IL-23 blocker, in a dedicated skin of color population. This is called the VISIBLE study, where about 70% of patients in that study had a Fitzpatrick skin type of 4 to 6. So we have a good representation of patients of color. And what we found was that at 48 weeks of being treated with guselkumab, we saw very good and robust efficacy. About 80% of patients are getting to a clear or almost clear, whether it's the body or the scalp. And the safety and the tolerability was also very good and consistent with what we've seen from their other studies. In that same study, we also looked at the impact that skin discoloration had on the overall quality of life. And what we learned from that study was that hyper or hypopigmentation could affect someone's quality of life more than actually the psoriasis itself, which really highlights why we need to get better at predicting who's going to get pigmentary alteration, but also how to adequately address it. Right now in psoriasis treatments, most of the innovation and success that we've had has been with our injectable biologics. We are at a point where 80 to 90% of patients can get to clear or almost clear with our shots. With our oral therapies, we are nowhere near that. There's a lot of work that needs to be done in the oral space, and while shots have become more acceptable for some patients, there are still some that prefer the convenience of a pill. But the problem is those pills are not as effective, sometimes not as well tolerated, and sometimes not as safe as the shots. At this meeting, we discussed results of 3 oral therapies that I do believe will close that gap between shots and pills. The first one that got recently approved here in the US is called icotrokinra. This is an oral macrocyclic peptide that binds to the interleukin-23 receptor with very high potency. We're talking picomolar potency, but also very high affinity, and it combines the benefits of a small molecule, which is small enough and stable enough to get absorbed through the gut, but also what we see with biologics is that it could block those complex protein-protein interactions between cytokine and receptor, and we're seeing efficacy that rivals some of our best biologics. At 24 weeks, nearly half of these patients are going to have clear skin, and the safety profile was excellent. It's pretty much what you get with placebo. So very reassuring and exciting to have one of those therapies available now. In the future, hopefully in the next year or 2, we'll also get approval for these next generation TYK2 inhibitors. These are improving on the first generation TYK2 inhibitor. These are more selective, more potent for the allosteric pseudokinase domain of TYK2. And we reviewed some of the phase 3 data for both zasocitinib, which is a once-a-day oral TYK2 inhibitor, and envudecitinib, which is a second-generation TYK2 inhibitor that's dosed BID. But in both of those studies, we saw efficacy that far surpassed what we saw with the first TYK2 inhibitor, which is deucravacitinib. It worked very quickly. We saw very good depth of response. And then the safety profile was very similar to what we've seen with the first generation TYK2 inhibitor, being overall very, very well tolerated, maybe seeing just a little bit more acne and very, very low rates of viral infections. But it's going to be an exciting time for our psoriasis patients here in the next couple of years, because now they have options and they get to really pick, do they want a shot, do they want a pill? So I presented the 16-week results from the Unlimited study. This is a phase 4 study looking at risankizumab, an IL-23 blocker, in a dedicated genital or scalp psoriasis population. As many of you know, genital and scalp psoriasis are considered to be high impact sites. So the impact on quality of life could be outsized or disproportionate to the relatively low body surface area that's affected. And we previously reported on the primary and secondary endpoints for the Unlimited study. But for this poster here at the AAD, we talked about quality of life, specifically using the DLQI, but individual components of it. And so the DLQI score, we typically report as a total composite score. There's 10 questions. But what a total score does, or what it doesn't do, is that it doesn't allow us to detect differences across the different domains in DLQI. For example, you can have one patient that has the same DLQI score. One might have persistent symptoms. One may have persistent embarrassment. So we want to know which one of these individual components of the DLQI is driving that impact on quality of life. So we did it for the scalp, we did it for the genital patients, and what we see across the board, whether it's symptoms, embarrassment, the ability to participate in social activities, your relationship with your partner, and your sexual relationships, that risankizumab was far more likely to get patients to a DLQI of 0 or 0.1 across all of these domains. And so it's always a nice thing when you see that a drug works well, not just for the skin clearance, but also for the patient-reported outcomes as well.